Based on the FLORA data, I have been using osimertinib as first-line therapy in patients who are diagnosed with either an exon 19 or exon 21. Now, what happens after osimertinib? Do we understand the mechanisms of resistance? Remember, T790M was the primary acquired resistance mechanism from first, second generation drugs. Osimertinib is a very good T790M drug. What are we seeing? Now, we don't have a lot of data, but there are a couple of series that suggest that there may be other mechanisms. There's another mutation, C797S, which affects the binding pocket for osimertinib, and that is an acquired resistance mechanism. The other thing that's emerging in these small studies, and I still think it's early, is that the rate of MET amplification, so another pathway, is much higher in this population. So I think physicians need to think about MET amplification, and we do have MET inhibitors there, and there have been some case reports that suggest that if you combine EGFR and MET inhibition, that in patients whose mechanism of acquired resistance is amplification of MET, then that may be an effective strategy. So I would, I think when we were using first, second generation EGFR TKIs, it became the standard of care to either rebiopsy or plasma test patients looking for T790M. Now that we have osimertinib in the first line setting and we kind of T790M is really not an issue at that point, is that you need to think about other mechanisms of resistance. I would continue to rebiopsy patients. I would look for MET amplification. I would resequence EGFR to see if you have C797S. I would look for a clinical trial in that setting. There's some preclinical data, this is interesting, that the first generation agents, gefitinib and erlotinib, may be active in the C797S subset. So we need some clinical data in that realm, but there's a possibility that even going back to a first generation agent after a third generation agent may be the appropriate approach in selected patients. Based on FLORA, osimertinib is the new standard. We've talked a little bit about the acquired resistance issues. Chemotherapy is still a good option for these patients. These patients tend to have perhaps maybe a better sensitivity to standard chemotherapy, so I wouldn't dismiss this. We had some recent exciting data from the IMpower 150 trial, which looked at the role of anti-VEGF in atezolizumab, a PD-L1 agent. And there was a subset of EGFR mutation positive patients in which there seemed to be a clear benefit of adding atezolizumab to the combination of carboplatin, paclitaxel, in bevacizumab. So that, to me, is an attractive regimen in the EGFR mutation positive population. I think we need more information about the EGFR mutation subset from IMpower 150. But again, I wouldn't give up on these patients. I think, again, chemotherapy is an option, and maybe some of these innovative strategies incorporating anti-VEGF therapy as well as immunotherapy may be important in this subset of EGFR mutation positive patients.